Hi, this is Brian Kim. I'm going to share with you case number 285 in the Best Way to Do Cataract Surgery series. And the title of this series is not to suggest this is the best and only way, but to get you to think critically of your technique so that you can provide the very best for your patient. So I see a wide range of lenses, soft lenses, up to hypermature brunescent, really raw cataracts. But in my practice, the bread and butter cataract is about a 1 to 2 plus dense lens. Again, not super soft, but dense enough that you might have to use any ultrasonic energy or fracturing techniques to fracture the lens in smaller pieces. And so this is a routine cataract surgery. You're going to see me using double chop, cross chop, and leveraging manual fracturing techniques. And this case will demonstrate the great holding power and purchasing power of this Veritas phacoemulsification system. So I use a corneal marker to help me center and size the rhexis. And then I make a paracentesis incision, first on the right side and then the left side, making sure I'm parallel to iris plane, which creates a nice corneal shelf, which will allow me to achieve a self-sealing incision. This is intracameral epinephrine, and then some dispersive viscoelastic to coat the corneal endothelium and flatten the anterior capsule. You can tell this is the right eye. I'm using that cannula to control the eye for my triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel through the cornea, and then when I'm ready, I enter. Using that same cannula to control the eye, and I don't move it at all from the left side incision, I switch to the Moria microrhexis forceps in my right hand, puncture the center, pull down towards me, and I go around circumferentially. And the way the forceps grasps, it has excellent control, very, very delicate, very, very refined. I'm able to grasp very easily. And the way the forceps works, the more you press down, the grip is stronger. It's just a really well-designed forceps for the capsular rhexis. Again, excellent chamber stability because of the low-profile nature of this forceps. And then I finish off the rhexis. This is the capsular fornix hydrodissection technique. I place a cannula under the rhexis edge contra-incisionally, get a nice wave, lift the lens up, decompress the bag. So again, a routine cataract, pretty nice big pupil in this case. So again, I wanted to show a big pupil case just to illustrate and demonstrate some of the techniques I'm doing. Irrigating the surface of the eye, adjusting the sleeve, and I'm able to toggle the continuous infusion on and off. I turn it off, lift the incision with a chopper, turn it back on, and then I remove the surface epinuclear material. And this is a double chop. I place a chopper under the rhexis edge contra-incisionally, turning the phaco-tip vertically sub-incisionally, bringing the instruments together and fracturing the lens in half. That is a double chop, placing the chopper under the right heminucleus, hooking the peripheral lens, pulling it centrally toward the phaco-tip and fracturing the lens in half as well. Grabbing that first quadrant with some vacuum. Again, it comes out so easy without any difficulty. And then once I grab it and hold it with the phaco-tip, I'm able to get around it with the chopper, crushing it with manual forces, and then emulsifying the lens piece. Turning the lens to get the second quadrant in front of me, sliding the chopper under the rhexis edge, and performing another cross-chop maneuver. Using some vacuum to pull that second quadrant up out of the bag, and then holding it with the phaco-tip, and then crushing it on the other side, flanking it, crushing it with the chopper, and then emulsifying the lens piece. Getting the second heminucleus around and turning it around, getting around the equator with the chopper and then crushing it with another cross-chop maneuver, and then using some vacuum to grab that third quadrant up. Again, holding the lens piece on the tip with the vacuum, crushing it with the chopper, and then emulsifying the lens pieces. Performing another cross-chop maneuver on the last piece, using some vacuum to lift it up a little bit so I can get the chopper around it, and then using some vacuum to grab that fragment up, and then getting the chopper around it and crushing it again. So again, this case really demonstrates very well how the Veritas just grabs and holds pieces so well with the phacoemulsification handpiece. Excellent chamber control, excellent chamber stability, no post-inclusion surge at all in this case. Posterior chambers pushed way back. I have excellent control, very efficient phacoemulsification of the lens pieces using the machine. I'm able to push the pedal just very gently and boom, it just disappears. The lens pieces just emulsify so efficiently with this machine. And again, excellent chamber stability, no post-occlusion surge throughout the entire case. Removing the epinuclear material now, some of it's rather stiff. So I take the chopper out, push BSS in, take the phaco tip out, and I go in with the INA handpiece, turning infusion off and then on using the foot pedal to toggle. Adjusting the sleeve, starting subincisionally, peeling the cortex from anterior to posterior. Again, peeling from anterior to posterior is the best way to get a clean capsular bag. Using foot pedal control to adjust and modulate how much suction I'm giving, and you can see the aspiration vacuum on the right side of the screen. Cataract surgery is a very dynamic process, and so you have to flutter your foot pedal. No different from when you're driving. You don't just put the foot pedal on a constant setting. You have to adjust your foot pedal as you go, as you drive. Same goes for cataract surgery. You have to modulate your foot pedal, adjusting the aspiration vacuum as you're peeling off the cortex. And you want to do it in an efficient way, but in a safe way, making sure you don't grab the posterior capsule. Polishing under the rexus edge with polish mode. Pulsing BSS into the subincisional capsule fornix, which is nice and clean here. Turning off infusion and then pushing cohesive viscoelastic to fill the bag, coming out with the INA handpiece, and then switching to the Singer Koch sweeper. You can see there's a little bit of conjunctival chemosis and conjunctivochalasis. Sweeping under the rexus edge, under the left side and then the right side. Using the Singer sweep to help me get the injector into the incision, and then switching to the cohesive viscoelastic to put a little dollop of cohesive viscoelastic into the bag, delivering the ZC-BU lens, and then using that same cannula I had in my left hand and disengaging the haptics off the optic, making sure both haptics are inside the bag. And then switching back to the INA handpiece. Infusion is off, and then I turn on. Getting underneath the lens, removing the viscoelastic from within the bag, and then polishing under the rexus edge, and then the anterior chamber, and then I'll hydrate my incision. So again, this is a routine cataract 1 to 2+ dense lens, dense enough that you had to use ultrasonic energy to emulsify the lens pieces, but not a terribly dense lens, just standard 1 to 2+. You saw a very efficient double chop, cross chop, using manual fracturing techniques to break down the lens very quickly. Within a few seconds, I have 3 pieces. And then excellent holding power with this machine. This machine is just so great at just grabbing pieces up out of the bag, the best I've experienced thus far. And so once you grab the piece up very easily, you're able to hold it with the phaco tip and then get around it with the chopper, crushing and flanking the lens with the instruments, crushing the lens with the chopper, breaking it up into smaller pieces. And then I've just pushed the pedal just a little bit and it emulsifies. The Veritas emulsifies the lens so efficiently. Again, because I broke it down already, it's very efficiently removing the lens pieces. I utilize less ultrasonic energy this way by using a combination of manual fracturing techniques and then having this excellent machine that has excellent holding power. I have great chamber stability, never had any post-occlusion surge throughout the entire case. Felt very safe and confident the posterior capsule was pushed back during the entire lens disassembly. And this ZC-BU lens is crystal clear, has great longevity as far as hydrophobic acrylic lenses are concerned, and this patient did great. So I hope this was helpful to you, and I thank you for your attention.